In this video, we shall learn the complexity of neuroendocrine tumors and how differently behaving tumors may be present side by side. Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon. And if you or someone you care about has received a neuroendocrine tumor diagnosis and you're wondering whether a single biopsy truly captures the full picture, you're in the right place. I know it can feel unsettling when your doctor talks about needing repeat biopsies or when treatment decisions seem to shift based on new tissue samples. But today we're going to unpack exactly why this happens with neuroendocrine tumors. By the end, you'll understand what makes these tumors so variable, why the Ki-67 measurement can differ dramatically between samples, and know exactly when to ask your medical team about re-biopsy. Let's start with the basics. Neuroendocrine tumors are unique cancers that arise from hormone-producing cells throughout the body, most commonly in the digestive system and lungs. What sets them apart from many other cancers is something called heterogeneity, which means the tumor isn't uniform throughout. Think of it like a marble cake rather than a plain sponge cake. Different areas have different characteristics. This matters profoundly to you because doctors grade these tumors using a marker called Ki-67, which measures how fast tumor cells are dividing. That grade, whether it's G1, G2, or G3, directly determines which treatments you'll be offered, from surgery to targeted therapies to chemotherapy. Before we dive deeper, let's establish what we're dealing with. This heterogeneity isn't just an academic curiosity. It's a clinical reality that can mean the difference between watch and wait versus immediate intervention. Within a single tumor mass, the Ki-67 proliferation index, that critical measure of how aggressive the tumor is, can vary dramatically from one region to another. Research shows that if pathologists don't have enough material for proper hotspot selection, that's identifying the most actively dividing area, and analysis of 2,000 tumor cells, undergrading can occur. What this means in practice is that a needle biopsy might sample a relatively quiet area of the tumor, leading to a G1 classification, while a different spot in that same tumor might be racing along as a G2 or even G3. Here's where it gets interesting. The European Neuroendocrine Tumor Society guidelines now mandate that pathologists count at least 2,000 cells in areas of highest nuclear labeling to get an accurate grade. The risk of undergrading decreases substantially between counting 200 versus 2,000 cells, and was minimal only when more than 2,000 cells were assessed. If you're looking at your pathology report and it mentions counting fewer cells, which often happens with small endoscopic biopsies, this is a conversation worth having with your oncologist. Perhaps even more striking is that the primary tumor and its metastases, cancer that has spread to other organs, frequently show different grades. Multiple studies document that metastases often have higher Ki-67 indices compared to the primary tumor. One study of liver metastases from small intestine neuroendocrine tumors found significant Ki-67 heterogeneity and World Health Organization grade discordance between primary tumors and their metastases. But here's where it gets more complex. Different metastases within the same patient can show varying grades. You might have multiple liver metastases, and each one could theoretically harbor different proliferative activity. Research examining liver metastases of pancreatic endocrine tumors documented heterogeneity of tumor prognostic markers affecting reproducibility. This means if you're supporting someone through this diagnosis, understanding that the cancer isn't one monolithic entity, but rather a collection of related but distinct lesions, is crucial for making sense of treatment plans. The technical requirements for accurate grading are more demanding than many realize. Pathologists must identify the hotspot, the area with the most Ki-67 positive cells, and then count a minimum of 2,000 tumor cells in that region. This is feasible with surgical specimens where tissue is abundant, but becomes problematic with small biopsy samples obtained through endoscopic ultrasound-guided fine needle aspiration. In this image, the Ki-67 staining is seen in brown. The guidelines explicitly state that grading is not recommended on smears from fine needle aspiration, though reliability is increasing with mini biopsies from endoscopic procedures. Think of it this way. If you're trying to assess a crowd's age distribution, sampling 50 people near the entrance might give you completely different data than sampling 2,000 people from the busiest area. The same principle applies here. Insufficient sampling leads to unreliable results. Neuroendocrine tumors can evolve over time. Well-differentiated tumors with initially low Ki-67 values can develop morphologically apparent high-grade components, representing a pathway distinct from poorly differentiated neuroendocrine carcinomas from the outset. Research has documented grade increases in gastroenteropancreatic neuroendocrine tumor metastases compared to the primary tumor. What this means for your care. If imaging shows tumor growth, or if symptoms change during surveillance, your medical team should consider re-biopsy. The tumor you had last year might not be the same tumor you have now, at least not in terms of its biological behavior. For patients with higher grade or FDG avid disease, that's tumors that light up on PET scans, Evaluation every 3 months may be appropriate until there's clear evidence of disease control. First, request a copy of your complete pathology report and look for specific information. How many tumor cells were counted for the Ki-67 assessment? Was the biopsy from the primary tumor, a metastasis, or both? Write down these questions for your next appointment. Was there sufficient tissue for hotspot selection? Should we consider a larger biopsy or surgical specimen for more accurate grading? If I have metastases, should we biopsy more than one site? Bring a structured conversation to your oncologist. If your tumor is being managed with surveillance, ask, what imaging or clinical changes should prompt re-biopsy? If you're on treatment, and it's not working as expected, consider, could tumor heterogeneity explain the response pattern? Would re-biopsy change our treatment approach? For those supporting someone with metastatic disease, ask about the specific sites biopsied. Given the potential for heterogeneity between different metastases, should we consider sampling multiple lesions? The medical literature supports this isn't excessive caution, it's evidence-based precision. While tumor heterogeneity itself isn't an emergency, certain scenarios demand urgent attention. If you develop new symptoms suggestive of carcinoid crisis, that's flushing, severe diarrhea, rapid heartbeat, and breathing difficulties, particularly before a procedure or biopsy, seek emergency care immediately. If imaging shows rapid tumor growth or new lesions appear, contact your oncology team within days, not weeks, to discuss whether expedited re-biopsy and treatment adjustment are needed. Let me quickly recap. Neuroendocrine tumor heterogeneity means a single biopsy may not capture your tumor's complete story. Your next step: review your pathology report and prepare specific questions about cell counts and sampling adequacy. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here which you may find valuable for further information on this topic, including the European Neuroendocrine Tumor Society, consensus guidelines on pathology diagnosis and prognostic stratification, and detailed studies on Ki-67 heterogeneity in neuroendocrine tumors. Full links are in the description below.